Andy, thank you for joining us this morning, Tuesday morning, the 27th. As usual these days, we've got a lot going on in policy, healthcare world. Y'all's predictions piece that you published, I think a few weeks ago now for 2026, I thought was a really insightful take on what might be ahead in the policy landscape, how we might be thinking about the world in 2026. So wanted to invite y'all on to come share your wisdom with us, help us learn as a community about where the puck might be headed. Obviously, we had a big development in the space last night with CMS dropping advance notice for 2027. So I might just start things off there. It appears from first blush, reactions that we're seeing publicly, stock prices being down 20% for the major insurers this morning, that advance notice came in lower than expectations. The market might have been expecting something like a 5% growth rate, and it's now what, 0.09%. I'd be curious how you interpret this. Like I saw in the predictions piece, y'all mentioned that Medicare Advantage is going to be the stable market in insurance in 2026 and beyond. It seems like this extends the instability in the market. But how do you process it all? What's your take on early read on advance notice?
Well, you think stocks being down 20% is a big deal?
I think there are some investors who are probably not too pleased by the billions raised to market cap.
Well, so a couple comments, and then I'll see if Andy has additional thoughts. Um, First of all, it was a surprise. Medical trend has been running, depending on who's asking, somewhere between, you see numbers as high as 8%. Um, they took a medical trend number that was, a little bit more than half of that. And so digging into what OACT, which are the actuaries at CMS, were doing is going to be interesting. But one of the reads that I saw on it suggested that there may be some adjustment for things like skin substitutes and other kind of fraudulent activities baked in there. And if that's the case, that would be good to know. That has actually been responsible for quite a bit of medical trend. Um, the other thing that is pretty apparent is that um, they have um, essentially said every risk code now is going to need a chart, and they have estimated that that's going to be worth a couple of percentage points or more, depending, of course, on how people risk code. Um, and that they estimated that deduction in there, and a couple of other coefficients that get you down to just about flat. Um, so I thought the most interesting part of their release, it was the three characteristics they highlighted as to how they were thinking about um, risk adjustment factors. One was simplicity to reduce day-to-day friction with providers. Second was really to level the playing field so that people who weren't sophisticated at risk adjustment, i.e., didn't have the ability to do all of the those non-visit codes, and third, accuracy and payment integrity and being budget conscious. Um, I think that's a pretty good read of like what they did. Um, and it is decidedly not friendly to the carriers. Final point I'll make is that I think people will say, well, every time there's a preliminary notice, the final ends up being higher. And that is true historically. I just wouldn't get very sanguine that that's really the game here. I do think it's likely that based on other factors that come in, you'll end up higher than this. But I don't think you'll end up a lot higher than this, if history's any judge.
Yeah, I think the only thing I would add there is, the administration is signaling that the traditional levers, there might be less juice to squeeze in the traditional levers, meaning the rate bump. And then when you think about, what are the levers that exist, the chart review, and making sure that we're only getting credit for conditions that are actively being managed rather than retrospective conditions that payers with larger resources might have the ability to dig through and help code to beef up that risk adjustment factor. So I think what I interpret this as from administration is leveling the playing field. As we know, one of their highest priorities is the element of choice and competition, and leveling the playing field of the regional payers with the big three seems to be one of the underlying motivators of this advance notice. So if it's not rates, which of course, we think that it might, the final notice when we hear back in, I think around April, will come out, it might be slightly higher than the 0.1% that was announced yesterday. But it's not going to likely be the 5 to 6% rate increase that people are expecting. So if it's not a rate increase and it's not a retrospective chart analysis from a risk adjustment factor that payers are deriving margin from, then what is it? And it really speaks to the focus on outcomes and the focus on accuracy and compliance. So I think from a founder and technologist perspective, if I'm speaking to the founders or technologists, I think I would, gear towards compliance. From a provider payer perspective, I think compliance will be incredibly important. I think narrowing the gap of like what levers there are to pull in terms of what juice there is to squeeze. It's likely less on the risk adjustment side and perhaps more towards quality and outcomes. So while we don't think that, we predicted that, and we're very willing and able to admit that we could be wrong here. I think, unfortunately, relative to the other risk pools, such as ACA and Medicaid, MA could still fare out pretty okay. And that's really just the lesser of multiple evils rather than actually being in a great place. Of course, I think payers are still going to be challenged in the Medicare Advantage environment because a lot of these levers that were traditionally quote unquote gameable or usable are going to compress. And I think this just speaks to the administration's focus on leveling the playing field across payers on the fee-for-service and original Medicare and Medicare Advantage side. And I think if you look, I was reading an analysis that CMS led that suggests that there is, from a risk adjustment perspective, as a result of V28 and the statutory coding adjustments, there's still some difference between Medicaid, Medicare Advantage and original Medicare, but it's a lot more narrow than anticipated. So more on the lines of, let's say, around 2%, which translates to around $5 to $6 billion in delta versus the original like $30 billion in overpayments that were anticipated. So I think just focusing on new, more outcomes-driven levers is really how I read this.
Two of the other things you touched on in your prediction that were also touched on in the advanced rate notice were around risk adjustment generally, which we talked about a little bit just now, and changes to the STARS program. I'm curious, as you think about how these changes, including the lower than expected rates, the overall shift in risk adjustment, and potentially another bite at the apple from CMS on V29 or something like that, and then the STARS changes sort of bleed through to the providers in the front line, because it's not just bad news for payers, right? These are capitated contracts that end up being financing providers as well.
Yeah. So it's a great question, Martin. I think on its surface, we ought to start by assuming it is bad news for providers, just because as the payers get squeezed, so too will providers, and there will likely be fewer MA markets and possibly even a reduction in MA, depending on where this lands. But I wouldn't jump all the way to those conclusions yet. In some part because there are people out there who don't code excessively, and they're going to see a lesser impact, number one. And number two, providers are going to have a chance because each code requires a file now, which is another way of saying it requires a medical visit. That will mean there should be more reliance on providers. So there's some good in here. It's I think as we pick through this, we've only had less than 24 hours, but as we pick through this, and as we get through the final notice. I expect it to be a little more balanced. I think Chris Klomp is very sensitive to the provider impacts here. And so one thing I would encourage everybody who, if you are feeling like this impacts your business and you're in the care delivery side, make that clear in the comment period.
I think we've been hearing a lot about this idea of the payer versus provider arms race. And I think if you look at the data, providers are winning right now in terms of uptake of AI tooling to better amplify their practice and better alleviate some of that administrative burden. So of course, I think this administration, as Andy said, is going to be more sympathetic to the providers rather than the payer challenges that will come from this. But I do think some of the changes, and I think some of the changes will be consistently flat. So of course, there's that 1.1% rate increase, which is essentially flat. And then if you factor in the few points of risk score trend that Andy mentioned before, maybe you're at 2.5% because of and that of course excludes like the unlinked chart review diagnosis. That's roughly like 1.5 in terms of headwind. So I think but one of the areas of consistency is the STARS changes in the advance notice that are relatively flat. So the quality measures that providers have been trained and focused on, skewing their practice towards represents an area of consistency, which of course is welcomed. But you could totally see downward pressure, particularly for like capitated primary care groups. And that's where I'd maybe point us to think about the uptake of new accountable care arrangements such as LEAD that provide the infrastructure for providers to better take on that risk and better manage that risk with elements like CARA. So I think, of course, providers will be impacted and likely impacted in the negative, but I think with the advent of technology and also on the policy side with new accountable care arrangement models, if we are able to, from a provider's perspective, better use those to our advantage, they could fare better than the challenges that the payers will face.
Andy Steinberg, you just led us exactly where we were going with the next question into value-based care, LEAD, CARA. It's interesting to me. I heard Chris Klomp talk at JP Morgan. It was part of the keynote on stage talking, and he made 2 points, as I recall, among others. One being his concern over whether or not we were being good stewards of taxpayer dollars in the Medicare Advantage market. Which I think you can see somewhat reflected in advance notice yesterday. But also, too, he said we need to be careful not to throw out the baby with the bathwater when it comes to value-based care in this country, and that we are still moving in that direction. He just renamed the team from fee-for-service Medicare to original Medicare as an indicator of interest in value-based care moving forward. So I'd be curious to drill down on that point, because I've heard a lot of interest in LEAD as a model moving forward, and in particular, this CARA program within LEAD as a way to drive VBC in specialty care. Could you guys expand on what you're seeing with LEAD and CARA?
Yeah, absolutely. So from, I think this administration, and it's not just this administration. I think that's actually one of the interesting consistencies across the last few generations of healthcare policy is this commitment to more and more people in accountable care arrangements. And I think the reason why that is the case is because, and especially right now, and if you ask yourself what's the why now, is I think this administration realizes, and also the private sector realizes, that for the reasons why value-based care has historically struggled, being really human intensive models for that care management, that staffing component to be able to actually exercise preventative care and identification of risk and management of risk. Those factors in terms of capital intensity, labor intensity, lack of consistency of models are diminishing with the advent of technology because you have from a technology perspective now, perhaps you could scale a care manager rather than managing 30 to 40 patients. They can manage maybe 200 to 300 patients. And that uptake, that lever in terms of that leverage that technology can provide will be really important to the scaling of more in accountable care arrangements. And it might not be those that have traditionally succeeded in these arrangements, so your scaled players. It actually might be new entrants who are redefining the way that managed care relationships and risk relationships work in healthcare with a very much so like a technology forward approach. And that is where something like CARA comes in, is because traditionally the uptake of subcapitation in lead models or ACO REACH models, which now will be lead, have stalled or stagnated or not necessarily realized their full potential because that burden falls on the provider to be able to handle the attribution, to be able to handle the payments and the contracting and defining what the data sharing looks like and managing that data sharing. And often providers, particularly those that are community providers and not part of large practices and large managed care groups or have struggled to be able to actually dedicate the resources to have to be able to be successful in those arrangements. So they default to not. So even though it's masked as a good amount of uptake for ACO REACH, like a lot of those are actually more so end up looking like fee-for-service arrangements. So I think CMS saw that and was like, how can we start to, one, leverage the technology that exists, and two, standardize the barriers to entry here, or standardize the playing field in terms of lowering the barriers to entry for that capitation or subcapitation, such that we can really see an uptake here. And then the reason why we're so focused on, and I think this administration is so focused on accountable care arrangements, is because it's really the only place where, because AI exists, it's not that we don't have the technology. Like the technology is not the barrier to adoption here. It's the payment model, because providers are volume incented towards volume and incented towards what they can bill for, which naturally makes sense. And today you can't really bill for a lot of the preventative services that AI might surface, or the preventative care that AI might be able to deliver. So now, if you move people into more and more accountable care arrangements, of course, providers and payers are focused on prevention and incented towards those outcomes. So I think it's both this dual movement towards enabling independent physicians, moving, I think that's a couple of goals. I think one, it's enabling independent physicians to remain independent, but also participate in accountable care arrangements, particularly those that are focused on sicker populations or live in rural areas. Two, I think it's about continuing to drive the uptake of technology that stands to really benefit both patients in terms of outcomes and providers in terms of that administrative burden. And then lastly, continue to push towards this goal of moving patients into accountable care arrangements such that our healthcare system actually delivers on what we want to deliver on, rather than volume that is not necessarily tied to strong outcomes.
If I could zoom out for a second, I think to misquote Mark Twain, the death of value-based care is greatly exaggerated. I had Dr. Oz and Chris on stage at JPM this last week or 2 weeks ago, and it's very clear that there's no better answer, and that as AI comes along and as you have things like pandemics, people realize that the fee-for-service system isn't going to get you there. And so I think we're dealing with the lull that comes from the early value-based care companies going public, who were, I think, mostly reliant on, many of them were reliant on the system that existed at the time, which is really a risk adjustment system. And so, the real success of value-based care are in organizations like Heritage in California, which don't overcode, but really get excellent results and outcomes. And organizations like that do exist. And I think what Chris and Oz would point to is you can be successful in value-based care, but you've got to get there by delivering better results. And so I think a generation to or a next wave of value-based care is hopefully on the horizon, where people will be using AI tools and other value-based tools to get to better results. And I think we all ought to be pushing for that.
Shifting gears a little bit to Medicaid, you in your piece described an actuarial reckoning. There's obviously lots of headwinds at the federal level between HR1 and then at this, flowing down to the state level with constrained state budgets and supplemental payments and provider taxes. As investors, how are you thinking about the Medicaid space going into 2026 and beyond? We've seen a couple rounds for value-based care pediatric platforms like Nest and Bluebird, and Pomelo obviously just raised a big round. At the same time, it feels like the headwinds are pretty ominous.
We're going to be investing in value-based care and Medicaid, and we're going to be investing in technology in Medicaid because we think the need is so great and the market size is still the biggest market in the world. Still in all, you have 57 potential Medicaid customers, and not all of them are created equal, and not all of them will be equally attractive. But we think that pediatrics, behavioral health, home and community-based services, targeted rural opportunities, targeted urban opportunities remain very strong investments and very strong investment thesis. And I think, we may look back on this period and say we over-rotated towards AI investing, and we rotated a little too strongly away from investing in care delivery that people need. When actually what we really ought to be doing is saying, how do we fix care? How do we make it better for people using technology? And I think that would lead us to be excited about some of the things that the market is slightly turning away from.
Yeah, I think as investors, we're, of course, not discounting the fact that it will be a harder Medicaid environment, but I think that is the really cool thing about investing in healthcare is that you get to lean into those areas that are traditionally hard to solve and that, perhaps others might run from. I think where there's the highest difficulty and efficiencies challenges is where there's the greatest opportunity. And I think it feels different now with AI. For the first time, you can actually realistically scale. And that's where we get most excited is, of course, your cash pay consumers are adopting and using AI to engage in their care. But those that have historically been overlooked by the healthcare system, which largely sit in a Medicaid population, for the first time, you can actually see a world in which we can use this technology to scale prevention, personalized services in Medicaid without, increasing on a linear scale on that one-to-one human labor ratio, such that you can actually make the math. And that's what makes us lean in here, despite the headwinds. I think, historically, high-touch preventive models in Medicaid break because you need that high intensity labor to work with low dollar amounts and low reimbursement from a Medicaid perspective, but AI perhaps can flip that. So I think of course, when we think about the highest areas of impact in healthcare, it's where the highest cost sits with like the smallest subset of members and the highest social needs. And that still looks like Medicaid. So I would say we're really, of course, saddened by the impact that some of the recent policy headwinds will have on a Medicaid population, but that's where we see the greatest area of opportunity for us to step in and support and scale both services and technology solutions that will not only just touch this population, but actually serve them in a fundamentally different way than they've ever been served before.
Last question from us, kind of bridging the two worlds of clinical care and AI. One of your last predictions in the piece was talking about clinical care as the next frontier for AI. We've seen a lot of activity here already in 2026, Doctronic and their pilot in Utah around prescribing medication refills. We've also historically seen some questions around, the use of chatbots for therapy and states trying to regulate that. Kind of two parts to this question. One, I'd be curious how you see the regulatory space playing out from this perspective. Is it federally regulated? Is it state regulated as practice of medicine, and pros and cons of that? Two, as you think about where the market's going in 2026 for entrepreneurs to be thinking about building, where the opportunity is in clinical care. How do you think about that from an investor perspective?
Did you see the piece in The Guardian, Kevin or Martin, the one on came out over the weekend, which basically said,
Good.
yeah, I think basic premise of it was don't experiment with AI on low-income populations was basically the premise. And I want to actively rebut that as a way of answering your question. We historically end up with new technology in these broadening the chasm of the digital divide, and as a result, broadening the outcomes that low-income and high-income people get. And this new technology, people are going to use it whether we like it or not, and we have to make sure it's available to everybody. So I would broadly refute that column. If you publish that column, maybe next week I'll write a rebuttal piece, but it's worth reading. Is AI going to do a perfect job of giving people clinical results? No. But I don't think this is the it's better than nothing argument. I think this is the argument which says people like this. People rely on it. Is it great for everything? Will it be flawless? Will it be perfect? No. But is it a better way for people to get care? And we'll define what it means. It will be undoubtedly some blend of the physicians available sometime. Technology helps guide you between visits. All of the models that we're seeing in the clinical side now will play out. And there's some incredibly exciting models. In the last week, I've seen models that 10x the capacity of a physician practice by giving the physician, by allowing lower level workforce to essentially do what physicians do. We've seen technology that allows consumers to record their own visits and keep track of what's happening and give them a to-do list out of every visit and communicate better with their physicians in the pharmacy. We've seen community health center technology that can dramatically automate how community health centers operate and provide care. These are good things, and I don't think we ought to be holding back on them. And I think we're entering an exciting era, and everybody that has the privilege of reading your newsletter, following your platform, being in this space today, is got a chance to be part of something that I think is really exciting.
Yeah, I think we totally wholeheartedly believe the next frontier of AI will continue to move into clinical care. And I think CMS is already quietly laying, not even quietly, but laying the groundwork for that with things like access and tempo, which we were really lucky to be part of. And I think they realize that the constraint is no longer like the technology itself, but it's the payment and the regulation to support it. So I think we'll continue to see the Innovation Center and CMS themselves come out with more infrastructure to be able to support the uptake of this technology. I don't think it's going to be a single AI code. I think it's more going to be targeted and focused with barriers and, of course, a glide path towards adoption here. But I think if CMS is able to show that what we believe will be true is that AI-enabled care will deliver better outcomes at a lower cost, then there's no reason why payment models shouldn't be built to support support providers being able to capture that value. And then, of course, commercial payers will be able to will follow likely as they have in the past. But you could see, founders leaning into this now that there's pilots like Access to support technology driven care that's tied to outcomes. And then people are already using this. I think OpenAI reported that over 40 million people use ChatGPT daily for healthcare related inquiries. So I think that speaks in of itself. Traditionally, we've had a really large engagement problem in healthcare of people engaging with their health, and that I think is enough of a signal for us to see and the administration to see that people are willing and able to use this across all age groups, even those that will surprise you in an older demographic are leaning into this. So I think there's no reason why this administration, particularly this year, I think we should expect to see more and more testing as it relates to this technology, and also relaxation of those limitations as it relates to barriers of perhaps like from an FDA perspective of your traditional like software as an MD designation, and relaxing of some of those barriers to accelerate the adoption of healthcare, and also empower the consumer. So Andy mentioned this idea of empowering the consumer to hold their data or engage in their care. And that aligns with this administration's focus on interoperability, in that if a consumer owns their data, they might be able to actually transcend the traditional barriers that have blocked the vision of true interoperability, in that they are the vehicle of their data and they become the vehicle of unlock for a vision of interoperability. If they themselves own their data and travel from visit to visit, from doctor to doctor, are able to actually empower themselves to engage in their care, which will drive better outcomes across the board. So I think we're really excited about that. And I think from our conversations with the administration, we've seen really strong alignment there.
Andy Steinberg, Andy Slavitt, we could spend all day on these topics. There's a lot of ground to cover, but we are at time for now. So appreciate y'all coming, sharing your thoughts and the thoughtfulness y'all put into your perspectives on the space and where things are heading in 2026 and beyond. Thank you for the time today.
Thank you, Kevin, and best of luck with everything in the Twin Cities. We're all thinking about you and thinking about the city.
Appreciate you. See you guys.